Good morning. My name is Sait Ashina. I am the Director of Headache Center at BIDMC in Boston, Massachusetts. I'm also Assistant Professor of Neurology and Anesthesia at Harvard Medical School. I would like to thank the organizers of this conference for this great opportunity to give the lecture on the chronic tension type headaches, classification, diagnosis, and management. Here are my disclosures. I would like to start with a few facts about the tension type headache. What do we know about tension type headache? We know that it is the most common type of primary headaches, and we also know that in its chronic form, it is one of the most difficult to treat. Unfortunately, tension type headache has been previously neglected, but lately, in the last few decades, there's been increased interest and improved knowledge about this primary headache disorder. Today, I'm going to be talking about epidemiology of tension type headache. I'm also going to discuss diagnostic criteria and classification, pathophysiology, and treatment of this primary headache disorder. Let's start with epidemiology. Here you see 1-year period prevalence for 3 most common primary headache disorders. These data are based on a population studies, and the most common primary headache disorder here is tension type headache, with a prevalence ranging from 38 to 74%, followed by migraine and cluster headache. Chronic tension type headache accounts for 3% of population. So in other words, 3% of population suffer from chronic tension type headache. On this slide, you see the data from a longitudinal 12-year follow-up study conducted in Denmark by Lundberg and her colleagues, demonstrating that the prevalence of tension type headache increases. You can see that the increase is significant, and it is more pronounced for patients with chronic and frequent episodic tension type headache. In this population study, Lundberg has also shown that among subjects with frequent tension type headache in 1989, 45% had remission when they were evaluated in 2001, 39 had unchanged headaches, and 60% had poor outcome. In other words, they had chronic tension type headache or headache on more than 15 days per month. Now, later we showed also that there are predictors for the poor outcome. So what are these predictors? Chronic tension type headache is a predictor. Coexisting migraine, not being married, sleeping problems, attack duration of more than 72 hours, unilateral headache, and nausea. So these are the predictors for the poor outcome of tension type headache, defined as continuous chronic tension type headache or transformation from episodic to chronic tension type headache. The epidemiological data also show that tension type headache is more common in females than males, very similar to migraine, but less pronounced, with a ratio of 1.2/1. Epidemiological studies teach us that the prevalence of frequent tension type headache is increasing, and the frequent episodic tension type headache has a favorable prognosis, but chronic tension type headache and coexistent migraine predict poor outcome. Let's take a look at diagnostic criteria for tension type headache. It is important to note that diagnosis of tension type headache based on the history, on what the patient is telling you. It is not based on specific imaging findings or specific blood tests because we don't have a biomarkers for tension type headache. These tests are only being made for ruling out secondary causes of headaches, such as tumors, subdural hematomas, etc. As you see here on the slide, there are two types of tension type headache: episodic and chronic. Division is made by the number of days per month. So if a person has headaches on 15 or more days per month, then that person is getting diagnosis of chronic tension type headache. If the person has headaches on 15 or less days per month, then this person is getting diagnosis of episodic tension type headache. In order to fulfill criteria for tension type headache, patients must fill the following criteria, two of the following criteria: bilateral location of headache, pressing or tightening quality of pain, mild or moderate intensity of the headache, and the headache must not aggravate by routine physical activities. And both of the following criteria must be met: no nausea or vomiting. Mild nausea is allowed in chronic tension type headache, and no more than one of photophobia or phonophobia. A lot of mistakes are being made in practice when we see patients, and patients may be having tension type headache but misdiagnosed with migraine and vice versa. Migraine is a very different headache. It is usually associated with significant nausea, vomiting, photophobia, and phonophobia, and the migraine can be aggravated by routine physical activity. So remember this diagnostic criteria when you're trying to make diagnosis of tension type headache. Here are the potential pathophysiological mechanisms of tension type headache, which involve possible genetic factors. It can involve peripheral and central mechanisms. Peripheral mechanisms include myofascial and to a lesser degree vascular factors. They may lead to peripheral sensitization of nociceptors. The central mechanisms involve central sensitization of nociceptive pathways and altered descending pain modulations. Let's start with the concept of referred pain. You may be familiar with acceptable terms of myofascial pain and myofascial trigger points. Dr. Janet Travel, who is next to the President Kennedy on this photo, was an American medical doctor and a personal rheumatologist to the US President John F. Kennedy. She was the first to propose the term of myofascial trigger point in 1942. In 1960, Dr. Travel teamed up with Dr. David Simons to further explore the realm of trigger points and myofascial pain syndrome. In 1983, they both published their work entitled Myofascial Pain and Dysfunction, Trigger Point Manual. This book was a breakthrough in the world of rheumatology, orthopedics, physiotherapy, and neurology. It changed the understanding and treatment approach towards the chronic pain. Since 1983, thousands of physical therapists, doctors, chiropractors, massage therapists, and other health professionals worldwide applied trigger point therapy in their practice. The pathophysiology of trigger points remains an enigma, but a study by Simons and his colleagues have claimed that abnormal electrical activity in focal points, so-called trigger points, may be the problem. And the trigger points may not be painful other than to direct pressure. When the pressure is applied, they may refer to pain elsewhere, as you see on these photos, to adjacent or remote areas. The origin of pain and the area where it manifests can be different. Here are the examples of the referred pain patterns from trigger points in upper trapezius, sternocleidomastoideus muscles, and splenius capitis and cervical muscles. The active myofascial trigger points were found in muscles innervated by trigeminal nerve, such as temporalis, masseter, extraocular muscles, and the muscles innervated by C1, C3 segments, such as sternocleidomastoid, suboccipital, and upper trapezius. Also, patients with chronic tension type headache have more myofascial trigger points than healthy subjects, which may be suggestive of the role of these trigger points in the pathophysiology of tension type headache. Here is an interesting study looking at the pain pattern in individual pericranial muscles. Experimental muscle pain was induced by the standardized infusions of 0.2 milliliter 1 molar hypertonic saline in the 6 craniofacial muscles: masseter anterior temporalis, posterior temporalis, trapezius, splenius capitis, and sternocleidomastoid muscle in 20 healthy subjects. And here you see the illustration of the subject-based and superimposed drawings of the perceived pain following the infusion of the hypertonic saline into the 6 pericranial muscles. The aim of this study, which was conducted by Schmidt-Hansen at the Danish Headache Center, was investigation of the pain sensitivity of pericranial muscles in patients with tension type headache. The experimental muscle pain was induced by standardized infusions of 0.5 milliliters of 1 molar hypertonic saline into 2 craniofacial muscles, anterior temporalis and masseter muscles. Subjects with frequent episodic and chronic tension type headache drew their habitual pain on the standard anatomical maps. The results from the entire group of subjects are superimposed on the standard drawing and shown here. There was no difference between the episodic and chronic tension type headache patients in the habitual headache pain intensity scores on the VAS. The drawings of the habitual pain demonstrated a pattern of pain localized over the entire visceral cranium, predominantly localized to the frontal and neck regions in the both frequent episodic tension type headache and chronic tension type headache, with no difference in the area of habitual pain between the two groups. Evaluation of tenderness by palpation is an important part of the clinical examination in many patients. In addition, evaluation of tenderness is an important tool in the myofascial pain research and can be part of the quantitative sensory testing. On this figure, you can see that the local tenderness score, which is the mean of right plus left sides, recorded by manual palpation at 8 pericranial regions. The data are presented as the means here. Patients with tension type headache, which are the red bars, were significantly more tender than controls, which are the darker bars, at all locations. The front indicates frontal muscle, mass indicates mastoid process, which is the insertion of the sternocleidomastoid muscle. Mass indicates masseter muscle, temporal muscle, coronoid process, sternocleidoid muscle, neck muscle inserters, and trapezius muscles. Triple asterisks indicate significant results. The study demonstrated that the increased tenderness in patients with tension type headache cannot be ascribed to certain locations or to certain myofascial tissues, but may be considered general for the pericranial region. Mean total tenderness scores in men and women according to the different headache disorders are shown in this figure. Both in men and in women, significant difference in tenderness between the headache diagnosis was found. In women, tenderness was significantly increased in chronic tension type headache, frequent episodic tension type headache, and in migraine compared with subjects without headache. In men, significant difference was only found between frequent episodic tension type headache and the subjects without headache. Women had significantly higher total tenderness scores than men, and the younger age group, which is not shown in the slide, had a higher total tenderness score than the older age group. The trapezius, neck insertions, and the lateral tigroid muscles were the most tender muscles. This is not shown in this slide. So if we summarize the importance of peripheral factors in tension type headache, we know that muscle tenderness and hardness is increased. Degree of muscle tenderness is significantly related to the headache frequency, intensity, and treatment outcome. Increased muscle tenderness in response to thigh exercise has been shown in patients with tension type headache. Experimental muscle tenderness precedes the headache. Decreased blood flow and muscle flow during the exercise has been shown in patients with tension type headache. To study central mechanisms of tension type headache, Lars Benson and colleagues from Danish Headache Center studied pressure pain detection thresholds, pressure pain tolerance thresholds, and cutaneous electrical pain thresholds. Pressure pain thresholds, as well as tolerance thresholds recorded in the finger, were significantly lower in patients than in controls. A non-significant similar trend was observed in the temple. The relative electrical pain threshold recorded at the labial commissure was significantly decreased in the patients compared with controls. Altogether, these findings of the general hypersensitivity to pain stimuli in the chronic tension type headache indicated that central factors played an important role in the pathogenesis of chronic tension type headache. To better understand the intramuscular and cutaneous pain sensitivity in patients with tension type headache, the intramuscular and cutaneous electrical pain thresholds were assessed by needle electrodes by three methods of testing: single pulse, 2 Hz, and 100 Hz in the trapezius muscle and extracephalic muscle, anterior tibial muscle, in 20 patients with chronic tension type headache and 20 healthy controls. P-value is from the three-way repeated measures ANOVA and post-hoc least squares differences test. The pain thresholds to three types of electrical stimulation, so single pulse, 2 Hz, and 100 Hz, were significantly lower in patients than in controls in trapezius muscle and in the skin overlying the trapezius muscle, while the electrical pain thresholds did not differ between the groups in the anterior tibial muscle and skin. So this study demonstrated that the increased sensitivity in nociceptive pathways from the cephalic region may be of more importance in the pathophysiology of chronic tension type headache and could be reflective of the segmental central sensitization. It has been suggested that superthreshold testing might be more sensitive than the threshold measurements in evaluation of central hyperexcitability in pain conditions. Subjective pain ratings measured by visual analog scale to both single and repetitive electrical stimulation with intensity of 1.5 times the individual pain thresholds were assessed in chronic tension type headache patients in this study. The pain ratings to both single and repetitive superthreshold electrical stimulations were significantly higher in patients than in controls in the temporal, trapezius, and anterior tibial muscles. In skin, there were also significantly higher pain ratings to both single and repetitive superthreshold electrical stimulation in patients than in controls in the temporal, trapezius, and anterior tibial regions. This study provides the evidence for the generalized increased pain sensitivity or hyperalgesia in chronic tension type headache and strongly suggests that the pain processing in the central nervous system is abnormal in this disorder. There are also imaging studies demonstrating that central sensitization is of importance in patients with tension type headache. In this study, which compared chronic tension type headaches to controls, decrease in the gray matter in the anterior and posterior cingulate cortex, insulae, brainstem, precuneus, and parahippocampus was shown. Decrease in gray matter was correlating positively to headache duration in years. These results indicate that most likely the findings are a consequence of central sensitization. To summarize all this, it has been suggested that the continuous painful input from the pericranial myofascial tissues may induce and maintain the central sensitization such that normally innocuous stimuli become painful, and we have a conversion from episodic to chronic tension type headache. This figure, which is published in the review on tension type headache in the Nature Review Disease Primers, shows the proposed mechanisms of the chronification of tension type headache. You see here that abnormal input from the myofascial structures in the head and neck, and to a lesser degree from vascular structures, results in the sensitization of the peripheral nociceptors. This increased nociceptive input leads to the sensitization of the second order neurons in the spinal trigeminal nucleus and the dorsal horns of the spinal cord at the level of C1 to C4. A beta fibers, which normally only respond to inocular stimuli, become pronociceptive and pain stimulatory. Dysfunction of the descending modulatory pain pathways results in decreased inhibition and increased facilitation of nociceptive transmission. This leads to the increased nociceptive input to the thalamus and sensitization of the third order neurons, which set impulses to the cortex. The result is the increased pain perception and chronification of tension type headache. The last part of this presentation will be on the treatment of tension type headache. Treatment of tension type headache can be divided in patient education, non-pharmacological treatment, acute pharmacological treatment, and prophylactic pharmacological treatment. Patient education is a form of non-pharmacological management. It includes information and reassurance about the disease state, information about the treatments, setting realistic expectations when you talk about the treatments and the prognosis, avoidance of trigger factors such as stress, poor sleep, irregular meals, caffeine intake, or too much caffeine, reduced physical activity. Identification and treatment of comorbid disorders such as migraine, depression, anxiety is very important. Physical therapies are probably effective. Relaxation exercise programs, improvement of posture can be recommended to patients. A biofeedback relaxation therapy, cognitive behavioral therapy has been shown to be effective. As a matter of fact, that if you combine biofeedback, cognitive behavioral therapy with medical management, it seems to be more effective. Physical therapies which are probably not effective include hot or cold packs, ultrasound, spinal manipulations, and it is questionable whether oromandibular treatments are effective in patients with tension type headache. Acupuncture may be effective for the treatment of the frequent episodic and chronic tension type headache. Psychological therapies offered at our headache center include cognitive behavioral therapy, biofeedback, relaxation training, meditation, psychotherapy. The main aims of these therapies include to reduce headache, to develop coping strategies, to increase quality of life. In summary, non-drug management should always be considered. Information, reassurance, and identification of trigger factors may be rewarding and helpful. IMG biofeedback has a documented effect. Cognitive behavioral therapy and relaxation training are most likely effective. More recently, mindfulness techniques have been implemented in the management of the headaches. Physical therapy and acupuncture may be valuable. Here is the list of acute drug treatments. Drugs with documented effects include ibuprofen, ketoprofen, aspirin, naproxen, diclofenac, paracetamol, and caffeine combination drugs. The questions always come when and which drug to start. It is most likely, but not proven, that ibuprofen 400 milligrams, aspirin 1000 milligrams, ketoprofen 25 milligrams are more effective than paracetamol. The rates for being pain-free 2 hours after treatment are approximately 30%. Ibuprofen and aspirin are recommended as drugs of first choice. So in summary, simple analgesics and NSAIDs are a drug of first choice for the management of acute tension type headache. Combination analgesics such as containing caffeine are drugs of second choice. Triptans, muscle relaxants, and opioids should not be used. It is very important to avoid frequent use of analgesics, including the caffeine-containing drugs, to prevent medication overuse headaches and the caffeine withdrawal headaches respectively. Prophylactic drug treatment should be offered or considered in patients with frequent episodic or chronic tension type headache. Drug of first choice for the management of tension type headache or chronic tension type headache is amitriptyline. Drugs of second choice are mirtazapine and venlafaxine. So how to use amitriptyline? How to start this treatment in patients with chronic tension type headache? It is recommended to start with information about the mechanisms and the side effects of the medication. It is very important to tell the patient that it is not related to depression and that you are not treating the depression and you're treating the pain, the headache. Start low, go slow. Start with 10 or 25 milligram before bedtime because it can cause drowsiness, but it may also improve the sleep in patients with tension type headache. Increase with 10 to 25 milligram per week to 10 to 100 milligram daily. Usual maintenance dose is anywhere between 30 and 75 milligram daily. Whole dose should be taken before the bedtime, as I mentioned before. Assess the efficacy with a calendar. Discontinue after 1 month of ineffective treatment. Consider mirtazapine or venlafaxine as the next choice. If effective, consider to taper off every 6 to 12 months. Here, I would like to give you some take-home messages about the treatment of tension type headache. The correct diagnosis of tension type headache is very important before starting the treatment, because the treatments of migraine, medication-induced headache, and depression may differ. Non-pharmacological treatments include avoidance of triggers, EMG biofeedback, cognitive behavioral therapy and relaxation training, physical therapy, and acupuncture. Pharmacological treatment include acute treatments, which are the simple analgesics and NSAIDs, and prophylactic treatment, which include antidepressants such as tricyclic antidepressants like amitriptyline or mirtazapine or venlafaxine. Thank you for your attention. I'll be happy to answer to your questions also by email. You can also follow us by Twitter at BIDMC Headache.